Uh, Hi guys, can you see my screen?
Yes, yeah.
Let me share a small testimonial video till the time people join.
Okay.
Dhruv, your recording prompt is there, so can you pause and deny or allow and replay the
Let-
testimonial from the beginning?
Yeah, let me replay.
And sound is not audible. Video sound is not audible.
Let me check. Can you now hear it?
Hello, my name is Shukuru from Congo Kinshasa, yes.
Varun, can we hear the sound?
I can hear Mr. Shukulu speak, but that music. Let's just go ahead. Let's go ahead. Don't waste time on
I had
it.
an accident in 2022, July. I had multiple fracture in my right leg. I had my first surgery in July, but my leg was painful. I had another surgery in December, but it was difficult for me. It was difficult because of time. It was painful every day, all the time. I decided to move out from Congo to get a good treatment. Flying visa from Turkish embassy. It was taking 21 days.
Nitumie tena, si ulikataa? Haya,
I meet Dr. Kawele. Dr. Kawele talked to me about Jivo. He told me that Jivo can help me with a good price to get a good treatment in India. I trusted him. The next day, we had a meeting with Jivo team from India. They told me about many hospitals. I choose Manimal, then Turkish doctor. It was easy and fast. Everything, they make it easy. After talking with the doctor, they send me a visa letter. I apply for visa to the embassy. After 2 days, I get my visa to India. And I meet Jivo team by the airport. They was waiting for me there. They fetched me to the airport, took me to the hospital. I meet a doctor, we talk. They did a surgery and everything was nice. Good people, they was with me all the time. If you call them, they was almost there. I get a good treatment. After some days in India, they got me back to the airport and moved to Congo. After that, they're still calling me, asking me how I'm going. I like really this team of Jivo. They really helping people because they help me. Now I can move without help.
What can I say about ça? J'espère que vous avez travaillé pour vous démarcher sans calme.
We but for a long time already. There is no more pain. I can move and I'm happy with all my family. Thank you very much, Jivo.
Hi guys, so that was a small testimonial by one of our patients who was recently treated. And I think as you can see in the video, earlier he was not able to walk, but then he met Dr. Kavele in Congo. He referred to us with the help of Jivo and the Manipal hospital here. And after the treatment, now the patient was able to walk clearly without any problems. So I think that's where Jivo can bring in a lot of value to you and your patients, where we can help you to connect with the best hospitals and best doctors available in India. We'll be starting with the conference in next 2-3 minutes. Just waiting for some more people to join. Ruth, can you please translate whatever I've said abhi tak, till now?
Okay. Sorry, before I translate, I just wanted to ask the doctor, the one in DRC, is it Dr. Kwele? How do you say his name? Sorry.
It's Dr. Kavile.
Dr. Kavele, I just want to ask him, is it possible for me like to mix French and the other local language that they also speak in Kinshasa to give me much of a balance? Because some words in French, I'm not too strong in them. Then I know in the other language that they also speak.
No,
Ruth can do it.
Okay.
French plus
That-
DRC local language.
this-
Idea is
yeah,
people
French
from
and
DRC should
Lingala.
understand. Yeah.
Okay. Thank you.
Ruth, could you please translate that what was the testimonial all about, like I shared?
Okay. So, les vidéos là, c'est pour monsieur, il a problème de les pieds, mais avec l'aide de Jové, elle va partir à Inde, et le docteur là-bas, il est aidé. Maintenant, il est rentré à Congo, il est ça va. Et en 2 minutes, on va commencer. Dans 2 minutes, tozo banda, so, tozo zela bat misusu bakota après biso nyonso to banda. Done. I think we can just wait for everybody else to join.
Got it.
Yeah, got it.
Dhruv, I think it's already 6 minutes past the event time,
I think
and
we can start.
we should start. If Dr. Puri is ready, we should start.
Over to you, Dr. Puri.
Yes, just a second. Hi. Good afternoon, everyone. I'm Dr. Anurag Puri. Can you hear me?
Yes, Dr. Puri.
Yes, good afternoon.
Yeah, I have one request. Can all of you please mute your microphones while Dr. Puri is talking? Please, humble request.
Yes, just a second. Yes, good afternoon, everyone. I'm Dr. Anurag Puri from New Delhi, India. I'm a urologist and a kidney transplant surgeon at Fortis Hospital in New Delhi, India. So I welcome all my friends from Africa for this webinar today. I will give you a small overview on the prostate cancer treatment and latest treatment guidelines. This will just be a small overview to gain more knowledge and make you better aware to how to deal with patients of prostate cancer, which is very much prevalent in your countries. Through the Jivo Network, we can create awareness amongst our patients and provide the best quality care there in Africa as well as in India as a referral center. So today, I will be speaking about prostate cancer. I hope you can see my screen.
Right. Dr. Anurag Puri, can we take 2 minutes for Ruth to translate for French-speaking people?
Okay.
Ruth, could you please translate the introduction of what Dr. Puri said?
Can you is my face showing? Am I?
Yes, Ruth, you are visible. Yeah.
Okay. So bonjour à tout le monde. C'est docteur ici. Aujourd'hui, il va parler comme les prostates de cancer. Il travaille avec Jover. Doctor can continue.
Yes. So the prostate cancer is the second most commonly diagnosed cancer in men, with about 1.4 million diagnoses each year and about 375,000 deaths worldwide every year. In Europe, it is the most frequently diagnosed cancer in men and the third cancer-related cause of death in men. The incidence of prostate cancer in Africa is believed to be very high. The incidence and mortality rates from prostate cancer are as high as 29 and 16 respectively per 100,000 people.
Okay. Le prostate cancer, c'est un grave problème en Afrique, en Europe, et beaucoup le monde et le problème de les 7 cancers.
Okay. So I got a list of all the questions from our African friends yesterday, and they were very much interested in what causes prostate cancer. So the risk factors include an increasing age. Prostate cancer incidence increases with increasing age. You can say that in the 80 to 90 year age group, 80% of men have some focus of prostate cancer in them on autopsy. And in the 90 plus age group, 90% of men have some focus of cancer in their prostate biopsy. So the increasing age is an increasing risk factor for prostate cancer, as well as a strong family history is a causative factor for prostate cancer. It is, as I told you, it is much more common in the African descent people and in the African American people. There are some dietary factors which are contributory as well. The nutritional, yeah.
Ruth, can you please interpret this part, these risk factors which Dr. Anurag just shared?
I'm talking about, okay. So, le prostate cancer, eza na makambo ebele esalaka moto azala nango, peut-être c'est les histoires de famille. So, famille na bino eza na cancer, bozwa yango, and also age to age. Soki age ezopusana, oza na risque ebele ya ozwa prostate cancer. Biloko mosusu mpe ezali eloko nini ozolia and ça.
Most of these prostate cancers, about 95% of them are adenocarcinomas, developing the acina of the prostatic ducts. Rest could be small cell cancers, mucinous, and endometrioid.
Ruth?
So na biloko ya cancer, liste yango eza awa, ezolakisa 95% ezokola na kati ya nzoto, and 5% ya batu, 5% de batu na Afrique ata na monde na liste nde soki ozomona oza na biloko oyeba cancer na yo eza na nzela oyo oza na cancer deja.
So the prostate cancer is most commonly found in the peripheral zone of the prostate in 70% of the times, and in the transitional zone about 20% of the times.
Okay. 70% de cancer tomona yango na 20% ya cancer bomona yango na se ya nzoto, après 70% eza na peripheral zone likolo ya nzoto, likolo ya corps, yeah.
Yes, the other questions which I got from your participants yesterday, that how does it present? So surprisingly, the early stage, which is the organ confined state, patients are asymptomatic. They usually are found to have prostate cancer on PSA blood test screening. Majority of them with organ confined disease are asymptomatic, but the locally advanced cancers can present with obstructive urinary voiding symptoms like hesitancy in urination, intermittent urinary stream, or decreased force of urination.
Cool, somebody that smokes too.
Ruth, please.
Okay.
Ruth, if doctor spoke many sentences, if you need any clarification, you can ask him, right?
I'm speaking.
Please, doctor, I feel like you're going a little bit too fast for me.
Okay, early,
Yeah.
the majority of the prostate cancer patients are asymptomatic. They do not have any symptoms. They are incidentally found to have prostate cancer because of blood screening tests like PSA test.
Okay, okay, that made so much sense. So ntango cancer ezobanda na kati ya nzoto bato mpenza bayebaka yango te parceke basymptôme ezalaka te me ntango okende pa docteur acheke masuba na yo acheke na blada na yo nde akomona basymptôme ya cancer. Thank you, doctor.
But some of the locally advanced cancers can present with some symptoms like obstructive urinary symptoms, like difficulty in urination, increased force of urination, increasing straining in urination, or blood in the urine, or blood in the semen.
Okay. Stage ntango ozomona oza na stage ya liboso ya cancer, c'est problème de urine. Tu vas à la toilette beaucoup parce que les urines est un problème. And ozala na problème ya kosuba na yo ezala mpe pasi. C'est un peu ça. Doctor, you can go on.
Yes. And some of the advanced prostate cancer patients where there is spread to the lymph nodes, they can present with other edema of the lower extremities, like swelling the lower limbs because of lymph node compression, as well as some perineal discomfort and pain.
Wait, doctor, would that be on your side of which side of the body? Sorry.
The lower limbs, legs, swelling in the legs.
The lower of the legs. Okay. So elo msusu soki olingi oyeba oza na cancer, makolo ekoma ovimba, omona mpenza makolo ekomi kovimba, pe makolo ekomi opesa o problème.
And many of the patients with advanced disease, where the disease has spread most commonly to the bones of the body, they can present with bone pains, fractures, paralysis of the lower limbs. So these are the manifestations where the disease has advanced and it has already spread to the bones.
Oyeba pe soki oza na stage ya cancer makuwa na yo na kati ya nzoto ebanda osala pasi, oyoka mpenza mokuwa na kati ya nzoto ekomi osala o mpenza pasi, oyeba deja cancer elingi ebanda o deja ekoti na nzoto.
So when the patient walks into your OPD and it's a suspected case of prostate cancer, what should you do? First of all, you can go for a complete proper history and an examination. The history should include a family history, his urinary history, and an examination should include a digital rectal examination.
Okay, soki omoni oza na basymptôme nyonso oyo docteur apesi, okende na hôpital, osala test and olandela pe histoire ya famille na bino mpona cancer.
Yes. And then you should offer the following tests. One is a PSA test, which is a blood test, where the blood PSA levels are measured. Any level above 4 nanogram per ml is suspicious of a cancer. It can also be increased in any urinary infection. Second test to be ordered is a urine analysis, complete urine analysis. And a third test to be ordered for any urinary symptom patient is an ultrasound sonography.
Okay, so osala test ya makila, osala pe test ya masuba test ya masuba na makila po oyeba stage nini okomi nango and then docteur akosunga yo.
So a digital rectal examination has low sensitivity and specificity for diagnosis, but we can pick up any nodule in the prostate, which is an indurated area, and it can be cancerous in 50% of the times. So all patients with nodule should be taken up for biopsy.
50% soki omoni oza na problème ya masuba soki bacheke makila na masuba 50% elakisa cancer deja eza na kati ya nzoto.
So the biopsy which is done is usually done by a transrectal ultrasound guided biopsy. The indications for a biopsy are an elevated PSA level more than 4 in the absence of any urinary infection and an abnormal prostate nodule found on a digital rectal examination. We usually take 12 scores of biopsy through the ultrasound guidance.
Doctor, is a biopsy a type of machine?
No, biopsy is we take with a needle, we take a piece of the prostate through the rectum.
Okay,
for testing.
Prostate, okay. Ntango baomona basali yo batest wana 50% wana pe elakisi 50% ya makila na masuba basalelo moko bazobenga biopsy eza kola injection batu bango na nzoto po deja babanda traitement.
So once the diagnosis of prostate cancer is confirmed on the biopsy, now we have to do staging of the cancer. The local staging of the cancer where it has spread locally is done by a multi-parametric MRI of the prostate, whereas a distant spread of the tumor is done by a PSMA PET scan.
Okay. Ntango bakomona na nzoto noza na cancer, basalela système moko boye bazobenga yango multi-parametric kolakisa nyonso na nzoto soki stage yango eza nanu mokie mais soki stage yango eza molai bazosalela scan na nzoto.
PET scan.
Scan moko bazobenga PET.
So the prognosis that the life expectancy depends on the histological grade and the extent of the disease. On biopsy, the grading of the prostate cancer is done by a Gleason score, which is a sum of two histopathological diagnoses, like score from 1 to 5, and the Gleason score is from 5 to 10. So a higher Gleason score, more than 7, is more aggressive cancer. A Gleason score less than 7 is a less aggressive prostate cancer.
Okay. Soki batali stage ya cancer na yo ya prostate, basalelaka système moko boye bazomergir yango mpo bayeba soki eleki 7 yeba stage na yo deja ekomi mpenza grave, soki eza na se ya 7 eza mpenza grave te.
So how do you stage the prostate cancer? There are 4 stages of the prostate cancer. The stage 1 is a prostate cancer which is not palpable at all. It is detected only on pathological examination, either via high PSA levels or when you do a prostate surgery for benign condition like TURP, on the biopsy specimen you find cancer. So that is stage 1 cancer.
Doctor, please repeat that for me.
Yeah. So there are 4 stages of cancer. Okay. And
okay.
The initial stage 1 cancer is the early cancer. It is non-palpable. You cannot feel the cancer on the prostate. You usually detect it incidentally, either when the blood levels of PSA are high or incidentally when you do prostate surgery for benign condition and on biopsy you find cancer.
Okay, let me say that first, then we'll move on to stage 2 and so forth. So, tozana 4 différents ya cancer ya prostate. Premier one, ya liboso, eza cancer oyo bakolongo penza te na nzoto. So, baosalela machine parce que eza na libandeli. You can go on, doctor.
Yeah, so stage 2 cancer, when it is palpable, when you do a finger examination through the rectum, you feel the prostate and you feel some hard nodule there, then which is confined to the prostate gland, then it is stage 2.
So in stage 2, can it be removed out of the body?
No. I'm just telling you how it is staged. I'll come to the treatment later. So in stage 2 is one where we can feel the prostate through the rectal area with the finger, and it is found confined to the prostate, not extending outside.
Okay. So to stage 2 ya cancer ba osalela ba osimba yo na nzoto na se ya urine na yo po batala eza cancer ya ndeni. So stage 2 eza koleka stage A.
And stage 3 and 4 are when the prostate cancer has extended beyond the prostate and it is extending to the surrounding structures and going outside the prostate.
So stage 3 na 4 eza stage ya cancer ya danger makasi parce que ezobima na kati ya prostate.
So the European Association of Urology has divided divided the prostate cancer into low risk, intermediate risk, and high risk disease. Okay, so the low risk patients are where the PSA is less than 10 and the Gleason score is less than 7, and prostate cancer is just limited to the prostate. And intermediate stage is where PSA is 10 to 20, or Gleason score is 7, or prostate cancer is present in both the lobes. You can explain these two first.
Okay. So na Europe basalaki différent balobi risque ya mukie soki eza na se ya 7, risque ya katikati eza 5-6, and then toza na risque ya likolo. I'm talking
for the risk stratification, 3 things are noted. One is the PSA level, one is a Gleason score, and one is a clinical finger examination test. With these 3 findings, we can stratify the patients into low risk, intermediate risk, and high risk patients. In the low risk patients, the PSA is less, the Gleason score is less, and on feeling the prostate, the cancer load is less.
Okay,
Ruth,
so
Ruth, if it is difficult for you to follow, Dr. Anurag can even speak smaller sentences. Don't worry. Just say so.
I think because I'm not used to the medical terms.
Dr. Anurag, perhaps you can tell by the logic.
I'll tell in a short way that we have to, before going ahead with planning the treatment, we have to stratify the patient whether he's a low risk, intermediate risk, or high risk disease. We see only 3 parameters for that. One is the blood PSA level, the other is the biopsy Gleason score level, and third is the clinical finger testing level. With these 3 parameters, we stratify the patient into low risk, intermediate risk, and high risk patients.
Ruth, you got that? Okay, I'll simplify it for you.
Okay.
I understood. Even I understood.
Okay, I can go ahead.
Okay.
So what are the treatment modalities available to us? So there are various modalities of treatment available. One is watchful waiting. If a patient is very aged, there was a question which was posed to me that I'm a 70 or 80-year-old person. Is there a treatment for me? Then we have to see whether the patient is symptomatic or asymptomatic. If he's asymptomatic, then and has a life expectancy less than 10 years, then we can do a watchful waiting. We do not treat the patient till he becomes symptomatic. That is watchful waiting. You can explain this first.
So na treatment, toza ba treatment différent. Chaque treatment eza par rapport ya stage oza nango. So soki oza na stage moko très compliqué, eza na ba problème ebele, baosalela therapy ya mususu. So ba stage yango eza awa watchful bas different traitement. So stage moko eza na traitement nango moko, stage mususu pe eza na traitement nango, ezo dépendre kaka na mutu cancer nini ya bamoni na nzoto na ye.
The second modality is an active surveillance, where the patient is having a low risk disease and early cancer, and he is willing to have a very good follow-up. We can follow up the patient by repeated biopsies and repeated examinations. And if we find that a cancer is increasing in size or progressing, then we go ahead for the treatment. Otherwise, we do just a surveillance.
Ok, soki cancer na yo c'est pas tellement grave, bazosalela système moko boye bazobenga yango
Ruth,
oui?
please
Okay.
stop.
Yes.
Yeah, please stop. Just repeat that active surveillance means that if the patient is active. First, speak in French. Use local language only where you don't have the French word. Okay?
Okay. I'm sorry, please just repeat on.
No, I'll summarize.
I'll
summarize what Dr. Anurag said. He said active surveillance means if the patient can be regular on follow-up, they monitor with biopsies or tests and see whether the cancer is growing or not. That is what is active surveillance. Am I correct, Dr. Anurag?
Yes.
Okay, so la active surveillance, c'est la stage comme les cancers, c'est pas tellement grave, et il va garder chaque fois tu viens à les rendez-vous. Il use les systèmes, les non-active surveillance.
Yeah. The next modality of treatment is a radical prostatectomy. It is mainly indicated for low risk or intermediate risk patients and also in selected high risk patients. Here we remove the entire prostate gland. It is the advancement today in today's life is that we do it with a robot assistance for better results and better continence results.
Okay. Troisième système de traiter cancer, c'est ardourine de dépression. C'est comme tant le cancer est un peu grave, baotala siko cancer na yo ekomi penza grave, so baosalela système wana.
Here, with the advancement of the robotic surgical systems, the patient's results are very good with respect to urinary continence. They are able to hold the urine very well and may also retain their erections. This is in advancement of the open prostate surgery, which was earlier advocated.
Sorry, doctor. Some people are texting in the comments saying that they can't hear. So I'm just trying to figure out why.
Okay.
Let me just
go ahead. You go ahead. I am replying to them. Maybe they are not connected to the audio. Okay.
Okay.
You go ahead translating what Dr. Anurag just said. What he said was with robotic surgery, results are very good. Patients are able to hold urine and also avoid erectile dysfunction. I think that's what you.
Yes.
Okay.
So, notre système de traiter cancer, c'est radiothérapie. Awa baloba nini okovanda na masuba na yo, so c'est radiotherapy.
Yeah, and the last modality of treatment is a radiotherapy. It is also indicated for early cancer diseases or can be used as a palliation for advanced diseases along with hormonal depletion or androgen deprivation.
OK. Traitement des cancers, c'est robotique. Ça, ça, les langues, stage, cancer, ils en ont na bandeli, premier stage. Doctor, you can continue.
Okay, okay. So this is too cumbersome to summarize. There are various modalities of treatment. So patients who are unfit or old patients, they can be put on hormonal depletion, like by injections to decrease their testosterone levels, or by removing their testis. That is one modality. Or they can be, if they are asymptomatic, they can be put on watchful waiting. You can translate this first.
Ruth. Ruth,
Are you
please interpret.
simplifying it for me? Okay.
No. Dr. Anurag, is it possible to share this slide as a picture for circulation to the doctors who attended today?
Yeah, sure. I'll just...
We'll share that. Okay. So I think that is for doctors, we'll share that. You can summarize the key message.
I can summarize that for early, low risk, intermediate risk, and high risk disease, there is an option for robotic radical prostatectomy. Radiotherapy is another alternative for that. This can be combined with androgen deprivation therapy in the form of chemical or surgical castration. Okay. And patients who have advanced disease or have metastasis, where the disease has already spread to the bones, there we go for more palliative treatment in the form of opening up the urinary passage along with androgen deprivation.
I think Ruth would not have understood all of that.
I think the English-speaking doctors would have.
But what I got for French speaking, we would translate it to French. You can move ahead, Dr. Anurag.
Yeah. And a word about hormone resistant prostate cancer. This is a form of cancer where the patient has the prostate cancer is usually dependent on testosterone, the male hormone. Okay, but sometimes in advanced cancer, it comes out of control of the testosterone. Even if we reduce the testosterone, it still increases. So this is a new set of patients which are hormone resistant. Can she explain?
Ruth, is it clear to you?
I think she's not there.
Okay. Yeah.
So I will summarize. There are patients who have prostate cancer, which is initial, limited to the prostate. There are patients which have prostate cancer, which has already spread locally. And there are some patients who have prostate cancer, which has spread distant to the bones. So the treatment varies according where the patient lands up. Sometimes the patient comes very late. The prostate cancer has already spread to the bones. There we have to, the treatment is different. Our main purpose is palliation as well as reducing his hormones by castration. When the patient comes early, our modality of treatment is curative. Then we go for robotic radical prostatectomy or radiotherapy. And when the patient comes with a hormone resistant, there are newer drugs like abiraterone and enzalutamide, which are latest advances which I wanted to speak about. Yeah, that's all I would want to. I would like to conclude here. If there are any questions, anyone wants to ask, they are please welcome to do so.
Dr. Puri, there's a question which says, what operation procedure is ideal for prostate cancer for a 74-year-old elderly?
Okay, so it depends that it's not the age only. Firstly, age is not the only barrier. if the patient has a lower metabolic age, he's fit and fine, moving around, okay, and and has a life expectancy more than 10 years. He has no comorbidities, then and the disease is limited to the prostate, low risk disease, then we can go ahead with the robotic surgery as well. But if the patient is a frail patient, is having difficulty to look after himself, does not have a very long life expectancy, then our treatment modality would be tapered according to his needs. If there is a urinary evacuation problem, we will open up that evacuation as well as give him a hormone ablation.
Is it clear to you, Dr. Kinsley? I think you can mute and ask if there are any follow-up questions.
All of you, thanks for joining. Now is the time for asking your questions to Dr. Anurag Puri directly. The purpose of this session is interactive sessions, and as doctors, you may have a lot of questions. Yeah. So somebody has asked which PSA test is more specific for the diagnosis, total PSA or free PSA? Dr. Anurag.
So, yeah. So PSA has to be interpreted with caution. One PSA report, like total PSA report is important first. Okay. One PSA report should not guide your biopsy. If there is a doubt, you can repeat the PSA after 2 to 3 weeks of the first PSA test. And if both the readings are high of total PSA, you can go ahead with the biopsy. When the PSA total is between 4 to 10 and you still have a doubt, then you must go for a free PSA test. If the free PSA test is less than 10% of the total PSA, it is more towards malignancy. If the free PSA is more than 25% of the total PSA, there is less chances of malignancy. So then you can guide your treatment accordingly.
There is another question. Who shall do ultrasound guided prostate biopsy? Neurosurgeon or interventional radiologist?
Both are doing. But
Anyone
a,
can do, yeah.
but a neurosurgeon is more adapt to deal with the complications if they occur, like bleeding or bleeding in the urine or bleeding per rectum. Then a urologist is better trained to tackle those problems, which an intervention radiologist would not be able.
Now another question is, this is from Dr. Harvey. The earlier question was from Dr. Messe. This question is from Dr. Harvey Basvikiti from DRC. So he asks, for robotic treatment, there is a specific stage to use this, or like what he wants to understand is robotic treatment is used for what stages out of those 1, 2, 3, 4 that you had outlined?
Yeah, so robotic is used for low risk disease and intermediate risk disease. It can be done for a high risk disease, but when the robotic treatment for a high risk disease, if the lymph nodes are positive, then we do not do a radical surgery. But if the lymph nodes are not positive, then we can do a robotic surgery along with an extended lymph node dissection.
Okay. So, Dhruv, there is a question by General Dima, Dr. Dima. A lot of questions were sent. If you can open that sheet and put them directly to Dr. Puri here. And because this is what users are asking, yeah. And
Right.
another
Yeah.
user has asked, should PSA test be sent to all BPH patients?
PSA test can be done, although it's not mandatory, and screening is not done regularly. But before starting any anti-androgen like dutasteride, which is commonly prescribed for BPH patients, we do a PSA test to know the baseline of the patient.
Okay, so I'm just going through the chat and I hope I'm not missing any question. Dhruv, can you open
Yes.
the
So
questions
I
or
have,
read from them, or just read from them to Dr. Anurag and he can answer, right?
right. I think the first question was the real causes of prostate cancer and can it be cured with erectile dysfunction and can it be avoided? I think doctor answered this question.
Yes.
Then the other question was the benefit of elzosine is the symptomatic
Dhruv,
management of.
Dhruv, always mention the name. No, we have to give credit to the user.
Right.
Yeah, who has asked
Sorry.
this?
So, Dr. Fesley Aman asked, the benefit of Elswozin is the symptom management of BHP and prostate cancer, or what is the new drug which you recommend in this regard?
Sorry, can you come again?
Let me present my screen.
Yeah, can you just open those questions here?
Yeah,
Yeah.
and there is Dr. Rabiu who has raised his hand. Dr. Rabiu, you can unmute yourself and you can speak.
Yeah, I have unmuted my mic. Good afternoon, everyone.
Good
Yeah,
afternoon.
good afternoon.
First of all, I would like to introduce myself. I'm Dr. Rabiu Salisu from Nigeria, Kano. And actually, I have to commend the presenter. Thank you for the wonderful presentation.
Thank you, sir.
I have a question regarding this presentation because it's something that's international. If to say, can you hear me?
Yeah, we can hear you, sir.
Okay, so my question is regarding transportation of patients from Nigeria to most likely India.
Okay, Dr.
So,
Anurag.
so how's the arrangement, and how will I confirm that this patient is patient that I can refer to Jivo Medical Healthcare?
That Dr. Anurag, okay, if I understood your question has two parts. First, how transportation is done from Nigeria to India. There are regular flights every day from Nigeria to India. So that's how transportation happens. Now the question is, how do you identify whether this patient is the case?
What severity, what the degree of prostate do you think I should recommend Jivo for this patient? At what,
That Dr. Anurag will answer.
Right?
Sorry, I couldn't understand the second part.
Okay, Dr. Anurag, second part is, when should Dr. Rabiu understand that this patient is serious enough that he should refer the patient to you through Jivo platform? That is what his question is. So either in terms of stage or in terms of severity, like the terminology, at what stage should Dr. Rabiu think that he should consult you through Jivo platform?
All stages of prostate cancer require treatment. Okay, and it would the earlier the patient presents to us in the earlier stage, if he's asymptomatic and incidentally detected.
Dr. Anurag, please go ahead.
Yeah, so I would say that all stages of prostate cancer require treatment, and the earlier the patient presents to us in an early stage when he's asymptomatic, the better it is. The results and prognosis and life expectancy and the cure rates are better if the patient presents early without any symptoms. He's incidentally detected. That's the best patient to have. But if he is having some symptoms and having complications from the prostate cancer, still he should send the patient to us. Every stage of the prostate cancer requires some form of the treatment. There some form of treatment or the other, which can be easily done here.
Okay, Dr. Rabiu, I'll add to what Dr. Anurag said. See, the purpose is not to send patients to India. The purpose is first to identify whether the patient will meaningfully benefit from travel to India. Yes. So for that, wherever you think that you do not have enough clarity, you just post a question to Jivo team. We'll post that question to Dr. Anurag and he will guide. I think
no problem.
Very simple way of looking at it, Dr. Anurag, is that right?
Yes.
Whenever there is a patient you think with Dr. Anurag's expertise, you can guide the patient. That should be the starting point. Whether they need to come to India or not come to India, that is secondary. That comes later on.
Yes.
Thank you for the wonderful presentation. I really enjoyed the discussion. Thank you.
Now, Dr. Brian has some questions. Dr. Brian, you can unmute yourself and ask. Dr. Brian has raised his hand. Dr. Brian, or Dhruv, till Dr. Brian comes on mic, let's move ahead with the next question.
Sure.
Okay, thank you, Chair. Yeah, this is Dr. Brian from Zambia. I am a gynecologist.
Okay.
I have a patient with adenocarcinoma histologically of the prostate. staged as the T4N0M0 and earmarked for evacuation to India for curative treatment. So colleagues were asking, what's the general outcome for a patient of this sort?
Sorry, I couldn't hear you.
CT scan does not demonstrate any metastatic disease
Okay,
at present.
Dr.
Thank you.
Dr. Brian, unfortunately, because somebody's mic was not mute and there was background noise. Actually, we both missed your
Okay.
question. Can you repeat it, please?
Okay, mine is I have a 51-year-old gentleman who has an established diagnosis of adenocarcinoma of the prostate, staged as the T4N0M0,
T4.
and CT does not demonstrate any metastatic disease.
Yes.
He's earmarked for radiation for now, so he's due to travel to India. In the meantime, he has been commenced on Zoladex.
Yes.
So the question we're asking is, what's the general outcome for a patient of this sort?
See, prostate cancer, amongst all the cancers in the body, prostate cancer is one of the slowest growing cancers. And fortunately for that patient, there is no metastasis, which would have to be reconfirmed when he comes in India, because I believe the PET scan facilities are very limited there in your continent. So,
No, Dr.
PSA
Anurag, in Zambia, we had confirmed it through another doctor. There is no PET CT scan machine.
Yeah, so that's what I'm saying. The PSMA PET scan, which is the newest modality, it is very specific for prostate cancer metastasis. So if he has a very high PSA and a T4 disease, as you're saying, there might be foci of spread. If the metastasis is there, then the prognosis changes a lot. But if the metastasis is not there, then he might have a very good life expectancy in spite of the disease.
So, Dr. Brian, I think the next step for you should be with the Jivo team on the work group. Please share the relevant medical details of the patient that you have. Let's get him opinion, like based on the reports, specific opinion from Dr. Anurag, and organize a consultation if he's interested. And we'll take it from there. Does that sound good? Yeah. Thank you. Somebody else had the hand up. Okay, Dhruv, move to other questions.
So I think, Dr. Anurag, this is the question by Dr. Faisal, where he's asking the benefit of L-leucine in the symptomatic management of BHP and the prostate cancer.
Alfuzosin is commonly used drug for BPH. It can relieve their urinary symptoms. And there are other drugs, newer drugs like Silodocin, which are more potent. So we prescribe either of them. Alfuzosin is more commonly given for a younger sexually active male, whereas Silodocin for an older patient because of its sexual side effects. I think the next question about ovarian cysts is more of gynecological. We'll change that. We'll move on to the next question.
I think this is something which you have answered, the recent one.
Yeah.
So why at the age of above 80, I'm assuming Dr. Simon believes that for someone who's above 80 years old, there is no treatment.
Yeah, so it is not the case that there is no treatment. It is usually that I told in the presentation that patients between the age group of 80 to 90, they have 80% chances of some foci of prostate cancer in the body, but they die of other causes. So it is bound to happen in them. And it would not be presenting as a disease in them. So sometimes we avoid treatment if the patient is asymptomatic and it is controlled because it's a low risk disease in this age.
So we have from Dr. Prince Ismail Dima. Dhruv, read the next question.
So the next question is from Dr. Prince. It's around pool prevalence on male performance suggests that as the male ages, his performance in bed weakens due to an increase in estophatic and digestive penis vessels. Is there any better explanation to this urologically?
Yeah, usually it's this is the case because of the atherosclerosis in the blood vessels. the blood supply to the penis decreases. So usually that is a cause of decrease in the performance.
All right, let me move to the next question by Dr. Atandas Solomon. What are the principles of prostate cancer management? I'm assuming you have discussed it. Aside medical or surgical interventions, any other curative management of the disease? What is the survival rate of the treatment? And what is the general prognosis of advanced prostate cancer management? And can it be locally managed?
So as I told in the entire presentation, the principles of management depend on the staging and the patient's disease parameters in the form of PSA levels, Gleason score of the prostate, as well as his clinical stage. So the survival rates change according to the stage of the disease. In the earlier or low risk disease, there's a 100% cure rate and with a very good prognosis. Even in the metastatic patients, because with the appropriate treatment, life expectancy is very much more than other cancers in stage 4. Glutathione has been is a newer thing which has been studied because of its antioxidant properties as well as in prostate cancer as well as in other cancers, but it is not a standard of treatment at present.
Got it. So I'll start with the next question of Dr. Oching. He asked, what does it take to have a kidney transplant? What if the generic makeup is different, which is leading to the failure after transplant, and what can be done to restore the kidney?
Yeah, so this is a topic which is unrelated to today's presentation, but it's about kidney transplant. So kidney transplant is usually the treatment of choice for renal failure patients, and the results are best when if you do it the transplant with a related uh, person, and there is a genetic match between the two. But even if there is not a genetic match or the blood groups are different, then you can go for plasmapheresis. It's an advanced form of treatment to lower the antigenicity of the organ.
So, Dhruv, please move to next question.
Right. I think next question was by Dr. Umau, where he was asking about the survival rate. I think this is something which
No, the question is, I hear that many patients get prostate operation
can meet death.
and meet death. Is it right?
No, I think this is
This
totally
question should be
misplaced.
answered.
This is a totally misplaced notion. We are doing it day in and day out. Prostate operations, a majority are done for the benign causes of BPH. Their patients are very happy and they go back with little morbidity because it's an endoscopic procedure nowadays. And even for cancer prostate, with the advent of robotic surgeries, there's just a 3-day stay in the hospital if such a big surgery is done, and patient is fine to fly within 2-3 weeks to his country without the catheter.
Okay, next question is in French.
I'll translate it.
You'll
We
have to
can go to the
translate it.
last question by Dr. Philip. He's asking, can the combination of penicidine and temozolin be comparatively eradicated like BHP?
No,
BPH, sorry.
this treatment is for symptomatic relief, not for eradication. The benign prostate hyperplasia, the tamsulosin relaxes the prostate to increase the urinary flow, whereas finasteride can decrease the size of the prostate. So these are not to eradicate BPH, but to treat and symptomatically treat the patient.
Dr. Anurag, we have two more questions from DRC. And so they want to know the difference when in approaches when you take, like when you, though you covered, but can you repeat? Because important, when do you go for chemotherapy?
Yes.
Do you go for radiotherapy, hormone therapy, oroectomy, or prostatectomy? So
Okay.
these 4 or 5 procedures are the universe of treatment,
Yes.
especially when patients want to come to India. So
Yes. So
for
if
which
the patient has an early disease which is limited to the prostate without any spread outside the prostate or to the lymph nodes or to the bone, then our intent of treatment is curative. There we go for either a robotic radical prostatectomy or a radiotherapy. Okay. Then if the disease is locally advanced, where the disease has spread somewhat outside the prostate, but it has not spread throughout the body or through the lymph nodes, then again we can opt for a robotic radical prostatectomy and radiotherapy along with an androgen deprivation therapy in the form of bicalutamide or other androgen depriving agents. But if the patient comes with a advanced disease whereby it has already spread to the surrounding organs and is not amenable to surgical resection, then we have to be less aggressive in the treatment. In the form, it can be in the form of radiotherapy or along with hormone deprivation. Then the fourth category of patient is where the disease has already spread to the bones. There is metastasis in the body. Here our intent is not curative. Here our intent is suppressive. So we have to suppress the disease. The suppression is by means of hormonal suppression. It can be either by surgical orchidectomy, where both the testes are removed, or by giving hormone depletion agents as regular injections 3 monthly or monthly. Then the
Another
last
question. Sorry.
last disease is hormone resistant disease. Here the disease, even after removing the hormone, the disease has become resistant to this. It has gone outside. It is not responding to hormone deprivation. There we have to add other agents like chemotherapy, like docetaxel, or oral agents like abiraterone and enzalutamide.
Okay, so another follow-up question, Dr. Anurag. It is in which cancer do you think it is necessary to send patient to India? And what can be done to prevent prostate cancer?
See, it's very hard to prevent prostate cancer. The main thing is that in the African continent, the prevalence and incidence of prostate cancer and the mortality is more than in the Asian population. So if you have when the patient has relatives who have been diagnosed with prostate cancer, there should be a more aggressive screening in those patients in the form of regular PSA tests from the age of 45 onwards in the African population. 45 age group onwards, there has to be PSA tests annually, as well as digital rectal examination by a doctor annually. So that is what we can prevent the mortality from it. We might not be able to prevent the incidence by this, but we will be able to detect early and prevent the mortality from it.
Okay, I have one more question in chat, and Dr. General Dima has his hand up. So, Dr. Dima, please you go ahead first, and we'll ask the question from Dr. William in chat later. Dr. Dima.
Yes. Looking at epidemiology, you would find out that nutrition really plays a critical role in the outcome of prostate cancer. So if you can go to that part, I think the first 3 or 4 slides, I want to find out from our specialists whether in the treatment of prostate cancer, dietitians are involved, or sometimes patients are referred to see dietitian, because the epidemiology tells us that the major. Hello, can you hear me?
Yes, Dr. Dima, we can hear you.
Yes, I'm a clinical dietitian, right? So I have an interest in how nutrition really plays a key role in prostate cancer development or outcome. So do we usually, in caring for our patient, refer them to the dietitian, because in the care for them, dietitians or nutrition play a key role in their healing. Apart from just doing most of the therapies, the principles on the therapies, you would need to see a dietitian to guide you, especially in management of your diet, which is key in recovery. So how often do we as doctors do that? Because it is of great concern to me. Thank you very much.
Yes, that's a nice question. Dietary factors have been proposed, although it has not been totally proven in prostate cancer that diet plays a very major role. But there are some nutritional factors which have a protective effect against prostate cancer in the form of reduced fat intake, reduces the chances of prostate cancer. Lycopene, which is found in tomatoes, has been promoted as a protector against prostate cancer. Then again, vitamin E and selenium have been promoted as a protector against prostate cancer. I agree that there has been less emphasis on this uh, in our daily talks with the patient. But yes, definitely, as a dietitian, I would suggest that this can be promoted, although there are no randomized control studies to prove their uh, protective effect.
Now we have a question from Dr. William from Zimbabwe. His question is, in your experience, how common is a hydrocele secondary to prostate cancer, and how can it be effectively managed in patients who are still undergoing therapy for the prostate cancer?
Hydrocele secondary is very uncommon in the prostate cancer. Uh, it it can be because of malignancy nearer to the testis. Okay, so I would suggest till the treatment is going on and the patient has not a very big hydrocele, you manage it conservatively rather than because hydrocele there is a secondary, it is a distant spread. So rather than going for any major surgery, you treat it conservatively unless and until it becomes very big and requires symptomatic relief by correcting the hydrocele.
So there is a follow-up question by Dr. Williams, and it is there a role for prophylactic prostatectomy for the prevention of prostate cancer?
No. This has not been proven as yet. There are some cancers like breast cancer where prophylactic mastectomy has been done. The very famous case of Angelina Jolie, who underwent bilateral mastectomy to prevent breast cancer in herself. But in prostate cancer, this has not been the case. It is more of a more aggressive screening in the relatives, the first degree relatives, male patients of the prostate cancer. And if prostate cancer is found, then to treat it accordingly.
So I think we have reached the end of the talk. If somebody has any more question, Dr. Anurag, can you field one or two more questions, or can we?
Yeah, I have no problem. Go ahead.
So anybody who has any questions, any of your patients facing any situation or general, Dr. Anurag has already agreed to share parts of his presentation or those slides which can be useful to you. Yes, we will edit
Yes,
the
hello.
recording. Yes, a doctor.
Yes, I wanted to just find out something. Hello, before we end. At what stage, this is Dima from Ghana, I asked an earlier question. I wanted to find out at what stage should a patient with prostate cancer should not be referred to India upon evaluation or evaluations, yeah. At what stage should we not refer? Or is it that every patient that we come across upon assessment should be referred? That's just the last question I want to find out.
Yeah, so it's a good question. Rather than asking who all should be referred, it's better to ask who all should not be referred. So it's a good question. I see all stages of prostate cancer require treatment, even if the patient is frail or he requires treatment. I would say that if you can handle that situation, that you can offer that treatment for that stage of cancer there in your country, it's best to do that. Okay, but where the modalities are of treatment and assessment are lacking, and all modalities of treatment like PET scans, radiotherapies, robotic surgeries, if they are not there, and if you are not able to offer 100% of treatment to the patient, then he should be referred. And also, if the patient is very frail, unfit to travel, And for any major procedure, then also maybe you can avoid sending them.
And Dr. Anurag, one question from Dr. Ambidin Salim. It was in the form, we missed it. Why do older people experience urinary incontinence? Why do prostates enlarge? What causes this? What are some risk factors for prostate cancer? Risk factors, I think you're covered.
Yeah,
But
risk factors I've covered in the presentation. Prostate enlargement also occurs with age. Uh, there are it can be genetic as well. And one thing I should make clear that prostate size does not decide the treatment. It is more of your symptoms. Even if the prostate is 100 grams and it is growing outside and it is non-cancerous, you do not require treatment. But if it is even 22 grams growing inside the urine, blocking the urine, and you're having symptoms, then you require treatment. So, and prostate size increases with age. So, that is, age is a very big factor in prostate size enlargement. And what is the other thing you were asking?
The risk factors that you already
Risk
covered.
factors I've
So now
already
we
covered.
have some user, we can't see the name, only Samsung phone number. They have raised their hand. Please go ahead, unmute yourself and ask the question.
Yes, my name is Wahab from Ghana. Yes,
Okay,
so
hi,
when
hi,
the
hi.
cancer, I have a cancer patient who is very weak, he's very frail, and he's unable to take the chemotherapy. So currently he's not on any medication. What should we be doing?
See, in prostate cancer, chemotherapy is not the number one modality of treatment. It is a last modality of treatment. First and foremost is hormone ablation in the patient. If you have not offered that, you should think of either giving hormone ablating injections or consider orchidectomy in him. If that is not suffice, because chemotherapy itself has its side effects and he can become worse uh, than he is right now. So first and foremost is to stage the disease and see whether initial treatments have been offered to him rather than straight away going on chemotherapy.
My suggestion in this case would be, sir, the doctor from Ghana, that if you have the patient history with you, the relevant medical information, you share with Jivo team, we'll direct that to Dr. Anurag, and then Dr. Anurag can guide you that what you can offer there, or
Yes.
if that person might help from intervention from India. So I think that should be the next step for you.
Okay, thank you.
Any more questions? So if no more questions, I would like to thank all of you for attending this talk by Dr. Anurag. My name is Varun Tomar and I am founder of Jivo Healthcare. Our purpose is to bring doctors who are practicing in Africa. We speak to, okay, there is one more question before I give vote of thanks. Is there a role for HIF? Dr. Anurag.
HIFU.
HIF.
Sorry, I couldn't see. Where is it? HI?
It's in the chat. Is there a role for HIF? Dr. William, can you ask the question directly? I think it's not clear.
It is HIFU. I think HIFU is the one he's asking.
Okay.
It is a newer modality in patients who are unfit for major surgery. So they can be offered HIFU treatment, but it's not the standard of care and it's not widely used.
Okay. So if no more questions, again, I'm Varun Tomar. I'm founder of Jivo Healthcare. The purpose of Jivo is to bring African doctors like you. We understand under what constraints you operate, and it becomes a cycle. Healthcare infra is underdeveloped. Diagnostic facilities are not there. But what we can do is, we cannot solve that today. In future, maybe, but not today. But what we can do is build a structured dialogue process with Indian specialists like Dr. Anurag Puri, so that you have a window to ask them any question which you think might help you manage your patients better. And if they intervention abroad, then you have a direct access to doctors like Dr. Anurag Puri and others, and can guide your patients better. So that is the purpose of Jivo. It is to augment your capabilities and slowly to help you perform as high performing doctors there with the remote assistance from Indian doctors. Now, we will keep organizing these talks. After this chat, you may have more questions after this, or your patients may have more questions. Please feel free to direct it to Jivo team. We will direct all your questions to Dr. Anurag Puri, and he will respond. And he will, wherever he can guide you to treat your patient locally, he will guide you. Wherever patient need to come to India, he'll help you evaluate whether they are going to benefit and should they travel or not. And if they would benefit by coming to India, he would give consultations and treat. We have a few successful patients which Dr. Anurag has treated, and they're doing well in their post-treatment phase and in their recovery. So with that, thank you all for your time. And these series of interactions we will organize every week. We'll pick different specialties so that you are able to support your patients better. Thank you all.
Hi. Hi.
Yes. Hi, Dr. Umu.
Good
Please.
morning. Thank you. Now I lost your contact. May I have a contact of Sumaya?
Dr. Umu, we'll reach out to you. I'll take your contact number. I'll reach out to you on WhatsApp.
Dr. Umu,
thank you.
Someone from Jivo team will reach out to you. Okay?
Okay, thank you.
Thank you all for your time, and thank you for being part of the Jivo journey. Let us create the largest healthcare network of the world, where top Indian doctors collaborate with you so that African patients can get better care at home or abroad. So we are here to solve cross-border healthcare delivery. And thank you all. It will be possible with contribution of all of us.
Thank you.
And thank you, Dr. Anurag, for taking time out on a Sunday.
Thank you.
That's the only day you get free, but thank you for this.
Okay.
Okay.